This is your host, Casey DeShock. Alaska Conversations is supported by a community of Alaskans dedicated to our state. If you'd like to view more information about the show, you can find us at alaskaconversations.com. There you'll be able to find this podcast as well as our show archive. The website is another place to find information and data concerning the topics we discuss, events, upcoming guests, and more about Alaska Conversations. If you have a question, comment, topic recommendation, or a suggested guest, you can email contact@alaskaconversations.com. This is episode 11. Today my guest is Dr. Gayle Hornberger. She is the owner and provider at Midnight Sun Family Medicine in Fairbanks, Alaska. Dr. Hornberger received her DO from the Chicago School of Osteopathic Medicine, and she's also quite the Alaskan, former pilot, Homestead and Lake Clark area, and been here since she was about 3. Dr. Hornberger, welcome to Alaska Conversations.
Thank you. It's a pleasure to be here.
So I just recently recorded a show about flying. It's had quite a bit of good reception. Some people have been a little bit upset with the guests that I had on or some of the positions that I took. I don't have a position in the medical field. I'm not involved in the medical field, but I do know that DPC practices in Alaska are pretty far and few between. There's not very many of them, and so that's why I'm really interested in talking about it, because it is a different model than the normal healthcare process.
It definitely is. I personally think that direct primary care is really one of the options to help boost American medical care out of the pit that we're in right now. But I'm quite certain that there are many that would argue with me about that.
Well, and I'm out and I record this show in Bristol Bay, in Dillingham. I think that you have a little bit of history with Bristol Bay, so maybe a little bit of what led you into medicine or a little bit about Dr. Hornberger, and then we'll jump into the healthcare issues and some of the medical issues.
Well, yes, I grew up in Bristol Bay, and my early exposure to medicine was actually Dr. John Libby, who lived with his wife in Dillingham, and they flew over the peninsula doing clinics in the villages, and so that was my exposure, and I guess you could say he always was somewhat of my hero.
Well, but I don't mean to interrupt you on this, but just so that this is just an interesting Alaska type of issue. I've never met you. You've never met me, but I did reach out to you to record the show. We haven't pre-talked about any of these issues. You knew things from Dr. John Libby. I currently live in... Dr. John Libby had one son named Jim, other sons, but I currently live in a house that I bought from Jim Libby, so from his son.
Oh my gosh, that's crazy. Alaska, big state, small town, right?
Yeah, it is.
Yeah. So, well, he was my medical hero, I guess. And when I went to school, medical school, I attended University of Alaska Fairbanks, and just to plug there, I think anybody can get a great education through the university system in Alaska. But did my pre-med there, went to school in Chicago, always wanted to come home, and my internship residency just got me closer to home. When I came back, I worked at our community health center here in Fairbanks. I had a 3-year National Health Corps payback, which I completed there at the clinic, worked a year there additionally. And then for personal reasons, I needed some flexibility in my schedule, and so I chose to open a clinic of my own, Midnight Sun Family Medicine. And Midnight Sun Family Medicine has been a very successful clinic here in Fairbanks. Started actually 9/11/2001, and we grew from that point to several years ago. Had a patient panel of about 6,000 and many employees, a large practice, very stressful, and just made the decision that I couldn't do it anymore. Had some personal health issues that caused me to kind of step back and take a look. And direct primary care just captured my attention. I felt with the model that I was in, which is pretty much mainstream medicine, where you might have a 15-minute time frame to see a patient, and maybe 7 minutes of that time frame is where you actually get to potentially touch a person or talk to them. I just felt that I was not able to provide the kind of medical care that I wanted to provide to people. And I should put a little blurb in and say that my focus is very preventative in helping people stay healthy. I always tell my patients, I don't tell you what to do. I'm your coach. I give you information, and I really want you to invest in your own health and work on your own health. So that being said, I think it's about 4 years ago now, I began researching, and with the help of I don't know what you call them, I guess a coach, I made the transition to direct primary care, and it's been a very interesting transition.
Well, I really want to talk specifically about the direct primary care model and what you have set up now. I'm excited to hear that it didn't necessarily start out that way, because you get to look at both sides of it. So we'll talk about the DPC model shortly, but first, let me talk about just the medical field structurally, because you talked about maybe there's DPC, concierge. Those are things that we'll touch on most of this show, and then you have the mainstream. And there's a lot of pros and cons to our system. I think that our system of healthcare produces a lot of research. It produces a lot of new technology, a lot of people that are coming to study and make profit, which benefit the world in general. But if there was one thing I could complain about in our system, it would be mainly the insurance and pricing. I know that you would tell me that I need to go to the doctor. I tend not to go to the doctor and get checkups. A lot of that is because of things that you touched on. I don't really think that the doctor's going to spend very much time talking to me. I have no idea how much it's going to cost me. So could you talk a little bit about why insurance, when you're talking in the mainstream, why it's structured that way, why pricing is hard to see, why insurance is difficult to understand for the consumer?
Oh my gosh, you've covered like 2 miles worth of topics there. But first, I want to reassure you and say that as a man, you are not out of the norm in not wanting to go to the physician. And I don't say that meaning to hurt anyone's feelings or offend anyone. But men tend not to go to the doctor, so don't beat yourself up for that.
Oh, okay. So I'm normal.
You're in the norm. You are. So, if we. I guess I need to say a disclaimer. This is my opinion. I'm not quoting anyone else, but in my opinion, a big part of the biggest part of where we're at in medicine right now is what comes down to the business of medicine. And the business of medicine is huge, and you touched on that a little bit. There's research, indeed. There's the pharmaceutical aspect, which is just really very predominant. There's the insurance aspect as well. And if we take a step back and look at insurance, I'm going to do a little comparison here. So if you buy car insurance, you do not expect your auto insurance to cover basic maintenance, right? Like oil changes or your brakes or your fan belt, correct?
Correct. And oftentimes we don't even consider that insurance is going to cover even some mid to major repairs.
Exactly. And so if we look at healthcare, my question would be, why do we expect healthcare to cover everything? And I've had this conversation with others, and people say, well, healthcare is so expensive. Okay, that comes back to the business of medicine, and we go back to insurance. Insurance is a for-business organization, correct? They are for profit.
Yep, for profit.
So the business of medicine, and I don't have exact dates for you, but health insurance really started back. And I'm sure there will be people that say, no, she's wrong. But health insurance really began to be an issue back with Kaiser when they were building a dam. I want to say it was Hoover Dam, might be wrong. But as part of a way to attract workers, they began providing health insurance for their workers. And sort of at the same time, Medicare was pushed through by the government and became an entity. And so there was the idea then of, coverage for elders initially. Anyway, through the early part of health insurance, you're young enough, you probably don't recall, but I recall having to go to Anchorage at one point to see a physician for something, and my mother saying, be sure to get the insurance paperwork. I have to file the insurance paperwork. So in the initial stages of insurance, people would go, they would see the physician, they would either pay or be billed, and the physician would give them their insurance form to file. And I suspect probably what became more of the norm is that to ensure that they got paid more quickly, because, people sometimes had to make payments and so on, and physicians' offices began billing insurance companies more as a convenience to the patient. It was easier. And from that, we now see, and I'm simplifying greatly, but from that we see the business of medicine, and insurance is a huge part of that. I'm going to just step back and say that I feel like I can speak to this with some clarity because I have seen everything from a very busy, successful mainstream medical practice to a direct primary care practice. And within my mainstream medical practice at one time, the cost of billing insurance for me as the owner of that practice was well over $100,000 a year. And so you might say, oh, whoa, well, what does that cover? These are things that a patient, an average person just doesn't understand about medical care. And that is that in order for us to bill insurance, we have to submit diagnoses with codes. There are certain codes that go with every diagnosis. And so a claim to insurance has to have those codes. If there's, I'm just going to throw a number out. If it's, say, E11.92, and that .92 is not correct according to the insurance company, they'll kick that claim back to us. And we might not be paid for, oh my gosh, I've got claims that are still pending for over a year, or I've had claims that were pending, for over a year. So just because you have insurance and you give the physician your insurance information doesn't mean that that physician is going to be paid. You follow me?
Right, and it doesn't have very much to do with exactly what that physician is going to get paid. That's one of the things with the
Correct.
pricing that I do know that. So when you were talking about Kaiser Hoover back then, there was some wage controls. If you go back into World War II, wage controls, you couldn't pay people a certain amount. Another interesting fact is that they made it illegal to do gold mining and horse racing, which were looked at as luxuries during the time. So
really?
which really hurt the Alaska gold mining industry up until we got back into the 1980s and it got more liberalized. But that's another topic. So employers got involved in providing the health insurance, but then when you get to the medical doctors, do some doctors with insurance charge different rates to different insurances? Is that how that somewhat works?
Well, no. Another mile worth of topics here.
Yeah, well, okay.
But I think maybe where you're coming from is more from the past where there was a disparity in charges. And again, I'm sure you're going to get all kinds of discussion about this, but there was a disparity in charges so that hospitals, institutions, clinics could provide some of that, I'm going to call it indigent care, but care for people who really couldn't afford care. But then the people who had insurance basically covered that care through the charges that were paid. Or maybe people who were paying cash and could afford it were charged more. And again, sure that will open a hornet's nest, but there was an agreement, and I'm sorry, I'm blanking on the year and the agreement, but there was a process by which the government and hospitals worked together. Gosh, I wish I could think of the name of the agreement. But anyway, there was an agreement, and hospitals were able to cover some of that quote-unquote indigent care because of this payment agreement or payment process. I'll have to look into that, and I can get back to you with it later on if you want. Nowadays, I don't think you're going to find that billing disparity. There's too much regulation in place. But what you do find is I do think that there are many hospitals that charge quite a lot. There are many hospitals that have purchased clinics and now have their own standalone clinics. They have urgent cares, and many people don't realize this. They think, oh, urgent care, I can go to urgent care, everything's great. Well, again, we come back to the business of medicine, and that is an urgent care can charge more for a visit because they are designated as an urgent care facility. So if a clinic, say, has a lovely big clinic and their family medicine practice is full, then someone calls in to be seen, that person can be shuffled through the urgent care clinic. It's an urgent care clinic, so the bill is going to be higher. Does that make sense?
Yeah, I think from my, how it works from the billing and how that urgent care center is getting paid more, I understand how that makes sense to me. From a consumer standpoint, I think it doesn't make that much sense.
Well, it doesn't, because it comes back to the business of medicine, and the average person, to which I mean no disrespect to anyone, but if you're not involved in medicine, you haven't experienced the business of medicine, you really don't understand this. But if I had an average mainstream medical practice and a person came to me, then they're an established person. We have codes. We have a 99211, a 99212, a 21314, and 15. And those codes all designate levels of service. And of course, the higher the code, the more intensity of service is provided, right? So if that person, first of all, if they're a new patient, it's a higher charge because they're a new patient. So there's more work of establishing them. So if a new patient goes to an urgent care, then they get a higher initial code, and then there's an add-on code that designates that care as having been provided at an urgent care center as opposed to in the clinic, the family medicine clinic, which I'm going to say because I'm a family doctor. Or if that person goes to the emergency room. Now, I don't do ER billing, so I can't speak exactly to that, but I do know that emergency room costs are higher, and I would say anyone who argues that with me would not really know what they're talking about, but emergency care is higher. I kind of segued around. Does that answer your question?
Yeah, so insurance is, I believe from my perspective, I'll just tell this story. We don't need to go into this, but so I've had 3 children. The 3 children have had vastly different experiences with all 3 of them. One child in the NICU, one child is a C-section, one child is a normal delivery. The costs super varied. For the C-section, I think we were receiving a bill maybe 9 or 10 months after our daughter was born for the first time. Called to it wasn't collections, but to their billing center and said, look, we just want to pay this to be to a 0. Just tell us how much we have to pay so that we can get to 0. And they said, well, we're not exactly sure because some of the stuff isn't the same provider. You've got multiple different providers that did the whole, because it was in Providence and Anchorage. So insurance generally is just super confusing, and it's something that consumers, I understand why they have a problem with it. But moving into the direct primary care, because we probably don't have enough time to cover all of the insurance, people are familiar with the mainstream medical service, what they're going to get. I think most people are relatively familiar with what that looks like. What is direct primary care? Because you've had both. So how has Midnight Sun Family Clinic evolved? How does it work as a direct primary care clinic? And what would the experience be different for a new consumer?
Well, let me start by saying that direct primary care, which I'm going to call DPC, actually came into being back in the mid to late 80s in the Midwest with a gentleman who felt like medical care could be provided in a different manner. And so that really was the birthplace of direct primary care. Also, Washington, I believe it was Seattle, Washington, there was a clinic there. And basically what direct primary care is, again, an analogy, I tell people it's kind of like being a gym membership. When you belong to the gym, you can You can go and you can use any piece of equipment they have. You can, take part in classes. If you want to tan, you might have to pay a bit extra for the tanning, or if you want to have a massage, you might have to pay extra for the massage. But your monthly membership fee covers most of what that gym provides, correct? You follow me?
Yep, absolutely.
Okay. So direct primary care works on the main premise. And I'm just going to step back and say the reason that a physician might want to do that is because, number one, with direct primary care, you can have a smaller patient panel. And I'm going to speak to some of the arguments against direct primary care as well. But
now, when you say patient panel, just for anybody that understands, that's just the reference to the number of patients that one physician is seeing, right?
Correct. So I will contrast when Midnight Sun Family Medicine was at its peak of profitability or success. The patient panel that we carried was about 6,000 patients. That's a lot of patients.
That's total, not per physician, though.
It is. It's not good. And now, a patient panel for a direct primary clinic goal is usually somewhere around 500 to 600, and so people can right away see the contrast. Number one, there's fewer people being cared for. The physician then is freer to work for the patient, and with direct primary care, it is a membership model. Therefore, you pay that physician or that entity a membership fee each month, and that membership varies. It could be based on age. It could just be a flat fee, which is what my clinic charges right now. It could be kind of a sliding fee. I think most clinics, direct primary care, charge on average somewhere from $40 to $150 per month. So that's a monthly fee. And let me step back and say the reason a physician might do this is it's a smaller group of people that they're caring for. It allows us to have the time to work for patients. Patients become the focus again. Insurance is no longer part of the factor. It's no longer part of the issue. And so we're not fighting with insurance to take care of people the way that we think they should be taken care of, the way that our guidelines direct us to take care of them. So it really returns control of that healthcare industry more back to the patient and the physician, and it helps us to reorient the person or patient back into the center of the healthcare experience.
Well,
okay.
Now, if you're in a larger, because a lot of people understand their family practice, the mainstream family practice in rural areas. I think that in smaller areas, anyways. But the majority of the people and where all of the noise gets generated on some of this mainstream topic is going to be in larger areas. Where let's say you're in a large hospital, you've got dozens and dozens of providers. You have administrators. You probably have consultants that are looking at Six Sigma type of efficiencies and consumer 1 through 5 returns, production by the physicians being directed, their schedules being directed by administrators that are saying this is the most efficient output for the hospital. So there's a whole bunch of things that go into that.
Yes.
So DPC is completely different.
Yes. So what you're speaking to is the business of medicine. And I just have to say, I saw a graph just recently that looked at administration versus physician, or I'm going to use the word provider, which I have to say I really hate, but providers versus administration. And the administrative costs are exponentially higher than the cost of physicians. So as part of that, as part of the public perception of medicine, again, the average person has this image of a physician where, physicians are rich. They make these hundreds of thousands of millions of dollars a year. And I'm going to tell you, there are physicians that make pretty amazing income based on their training. I know heating, plumbing specialists that make more than I do hourly. So if you want to blame the cost of medicine on physicians, I'm going to say a person on physician income, a person should then take a look at the cost of the business of medicine or administrative. So what you've just spoken to is the administrative slash business of medicine. Okay. So when you step into direct primary care, I'm going to come back to this. It's a monthly fee. And what does that monthly fee cover? Well, like in a gym, it covers as much or as little as you want to use that medical practice. It covers checkups. It covers routine care. It covers sick care. It covers in-office procedures. It covers, believe it or not, I do house calls. It covers personal care. Visits are 30 to 60 minutes. My average visit now is probably 20 to 40 minutes. So we could say an average of 30. My patients don't wait. I have a lovely waiting room, but you know what? They walk in the door and we're like, come on in, we're ready for you.
Which a lot of people could appreciate that.
Right. And so then I always tell people it's direct primary care. You have direct access to me. My members have my cell phone. Just recently, I'm at my desk working, my cell phone rings, and a patient who's in Singapore is calling me because she's in Singapore and she has an issue and she doesn't know what to do. What should she do? And I was able to help her through that health issue so that, number one, her vacation wasn't ruined, and number two, she wasn't thrown on the mercy of an unknown medical environment. Now, that's, there might be issues where a person does have to go to the hospital in Singapore, but with direct primary care, you have access to your physician. And I always tell my patients, please don't call me just to chat. And if it's 5 o'clock in the afternoon and you're feeling sick, don't wait until midnight to call me. Call me at 5 because I have a life too. And honestly, my patients respect that. They don't abuse it, and I appreciate that very much.
So you can get checkups. Now, I went onto your website, and I'm just looking at the family. So you've got it listed. Prices may be different now, like $3,600 is in the neighborhood of your yearly fee for a family.
Right.
And so if I compare that, I do not have a DPC anywhere near me in Bristol Bay. Our insurance costs are, when I calculate it out for the year, we do not have employer sponsored health insurance. We pay for it entirely privately. It's over $20,000 for the family, and we have over a $10,000 deductible. So that's basically catastrophic insurance.
That is catastrophic, yes. Mm-hmm.
That is very expensive compared to $3,600. So I've got children. Can I bring my children in if they've got a little sore throat or something like that? Is that the type of thing that a DPC is taking care of?
So that's going to depend on your physician. I am I'm a diehard family physician, and I tell people from the cradle to the grave. So unfortunately, I don't do obstetrics anymore, but I love children. I love seeing children. I have taken care from the cradle to the grave. Not every physician may follow that. Some physicians may want to focus more on adult care, but a person who's coming to see me, I do have children. I have elders. Last summer, I did home visits on a weekly or more frequent basis for a woman who was end-stage cancer, and we were able to allow her to die at home because I could do home visits for her. So does that answer the question?
Yeah, so if I have a child, so they're going to vary for DPC. If I'm supposed to get a checkup a year, maybe?
Well, that's a little controversial now with our national guidelines, which okay. The patients of mine who listen to this won't be surprised when they hear this. I don't always agree with our national guidelines, but on a yearly basis, you should touch bases with your physician.
Okay, so if I come in and talk to you and you tell me, hey, Casey, your blood pressure is a little bit high, and maybe there's one other thing to look at. I don't know. I'm not, like I said, I don't go to the doctor very often. I need to start. Now, are you working with the same monthly fee that we have? Are you working with me to manage my blood pressure, get me whatever medicine I've got to take, some lisinoprol or whatever, you're helping me manage this and get it back down to normal? Or is this something where I'm going to have to leave and go somewhere else?
So, as a family physician, we are trained to take care of, I'm going to say, the common and some uncommon ailments. But yes, as my patient, you would come in because it's direct primary care. Your monthly fee covers however many visits you want to come in or however many visits we think you should come in for through the month. And I help you get your blood pressure down. Many direct primary cares do provide or they have access to generic medicines at low cost. That's not something that I have right now, but I work really hard to help people get their medications at low cost. So we'll go to different pharmaceutical companies and get their patient assistance forms and that sort of thing, and we help patients get their medicines at low cost. For children, for vaccinations, what I do is what is in the clinic. The vaccinations that I have in the clinic are charged at cost or wholesale plus 10 to 15%. And I say 10 to 15% because you know what shipping is like in Alaska.
Yeah, absolutely.
And so that covers my shipping fees. And if I don't have the vaccine in the clinic, then we refer to the public health clinic, or I'll send people over to the pharmacy, which I'm not as happy about. But vaccines are quite expensive, so I have to be careful with a lower patient panel. You know, if I get in, say, 10 measles, mumps, rubella immunizations at the cost of almost $2,000, and then I only use 3 of them before they expire, then that's not cost effective for me.
So you, for vaccinations, you would just do the normal, the recommendation, or just that's on your discretion. You know generally what vaccinations you recommend. So you do these. So I can take my children and get them into a kindergarten or a first grade because you have the number of vaccinations. I still have to pay my monthly membership, and it's going to cost me a little bit of extra for the vaccinations, but it is going to be at cost. So it's going to be plus 10 or 15%. Right. So it's going to be cheaper vaccinations, but it is additional to the cost, my monthly cost.
Right. It's cost, or my wholesale cost, plus 10 or 15% depending on shipping, which in actuality, I haven't done a price comparison with the pharmacies, but that is cheaper than most of the pharmacies in town. On general, I think that most places probably double the wholesale cost of vaccines. And then there's an injection fee as well. So if a DPC patient receives a vaccine here, it's cost plus 10 or 15%. And that's above the membership fee.
Well, and even if you're doubling it, though, as you mentioned, I went through the numbers with looking at your clinic and looking at what I do. And that's what I'm talking to you about is I've got to come up with roughly $27,000 of cost to make it more expensive for me to go see you than to stay with my normal insurance. That's where I'm at right now when I'm looking at my numbers. So
yes.
Now, if there's some sort of injury, like a broken leg or anything, and this is just because you have to assume that I don't know anything about family medicine, that I'm going to have to go to a different clinic. That's something I'm not coming to see you for.
If you have a broken leg, the likelihood is that you will end up in the emergency room. I do not have x-ray capability in my clinic. And if I look at you and I strongly suspect you have a broken leg or a broken arm, that sort of thing, you most likely will go through an urgent care, which would then send you to the ER. I usually tell people just go to the ER. But so yeah, that's a problem. I do some splinting and casting here in the clinic. I will be very honest and say I am not a specialist at it, and because it's a direct primary care, again, coming back to the cost of medicine, I don't have a designated cast person, right? Okay. So you will probably end up going to the ER, and they will splint you, or if you come to me, I'll be like, oh, yeah, crikey, your leg is broken. Let's get you splinted. Let's get you to the orthopedist. make sure that everything's set the way it should be, because we don't want you to have long-term deficits. And then a lot of times when people end up going to the ER or something like that, they go to the orthopedist and then they come back and they do as much follow-up care with me as they can. And I have folks that go, for example, to Idaho for spinal surgery. They go down, they get their care, they finish up, as the physician wants them to there, and then they come back and they do follow-up care with me, and I coordinate that care with the doctor in Idaho. So I'm just going to add in here that many of my patients belong to health-sharing entities, and I'm going to throw a few names out: MediShare, Samaritan, United. I think there's Republic. So there are health-sharing entities, which is like a healthcare co-op. And what these individuals find is that it's cheaper for them to pay for a direct primary care membership, know that their primary care is being covered, and then if there's something catastrophic or a larger fee, something that happens and their charges are higher, that cost-sharing entity will help with the payments, and I refer to the specialist as needed. Does that make sense?
Yeah, that makes sense. And so another piece of this is going to be so managing long-term chronic type of conditions like diabetes, these types of ailments. Is that something that your clinic or other DPCs would be doing, or is that something where you may be better off going over and having somebody that specializes in managing those types of ailments?
So again, Casey, I'm going to tell you, you're just breaking up just a little bit. I can still get the gist of what you're asking. But the answer to your question is family physicians go to 4 years of medical school, just like all other medical students do. And then family physicians additionally have 3 years of specialty training in family medicine. And again, it's considered from the cradle to the grave. So we learn pretty much everything, all aspects of the common ailments. So congestive heart failure, diabetes, hypertension, cholesterol, obesity, anemias. I have people with thalassemia. I take care of people who have had kidney transplants. I don't have any heart transplant patients right now, but I've taken care of them in the past. So the answer to your question is yes, a residency-trained family physician, and I'm emphasizing family physician here because I do want to speak to the term provider. A residency-trained family physician should be able to help a person care for their medical issues. And if there's something, for example, our national guidelines require diabetic patients to see a nephrology to see a kidney doctor, a nephrologist, if certain things are present in their health issues. And in fact, this comes back again to the business of medicine. If I have a diabetic patient who has not seen a nephrologist in the last year, or there is not evidence on their chart of seeing a nephrologist, I potentially can have what I am paid for seeing that patient reduced because the insurance company can say, well, you didn't send the patient to the nephrologist. So
and
kind of segued there.
What's the nephrologist?
That's a kidney doctor.
Okay.
Kidney specialist.
Yeah,
so a family physician, a board-certified family physician, should be able to take care of the majority of your health issues and should be able to refer as needed to the specialists who then do a consult. So, for example, if you came to me with diabetic kidney disease, I would say, oh gosh, Casey, we need you to go and see the kidney specialist, the nephrologist, and I would refer you to the nephrologist. The nephrologist would take the labs and the studies and everything that we've done before you go to the nephrologist, and that specialist would review everything. They would talk to you. They would do an exam. They would order any additional studies that needed to be ordered, and then they would provide a consultation report back to me saying, well, Casey looks really great. His numbers are good. His blood pressure is a little bit high. Let's raise the lisinopril dose. Make sure you keep him on this type of medicine. I'll see him back in a year. And then we carry on within my practice, and I monitor numbers, and we monitor blood pressure, and I help you take care of your health.
So, when a lot of people are thinking about health insurance, I could be wrong on this. I'm just in my conversations with individuals. A lot of people are worried when they talk about health insurance, health care. They're more worried about the major things. They're not looking at what a family care provider or a family care physician is doing. I know you don't like the word provider. I want to give you a chance to tell me why that is here in just a second. But most people aren't looking at the preventative. So when I think about a direct primary care model, when I'm reading about it, I don't know anything about that as far as I've never been to one. I've never used one. I'm initially thinking, okay, I'm going to pay this small amount relative to what I pay right now in insurance, and that's going to get rid of my need for insurance. That's not the case. What it looks like here is that the DPC model is going to take an individual, and it's going to substitute you going to a major mainstream clinic and perhaps not getting the adequate or the best possible preventative care. It's going to shift it. So now you shift it over to a DPC model where you get twice as much time with a physician on call, and you're doing a better job preventing future catastrophic, or not catastrophic, but future long-term ailments. So it's more of a prevention thing. It is going to be an added cost to the customer, to the consumer in general, kind of. It's hard for me to explain exactly how that would be, but if you still need to, if I'm a family and I still need to hold on to insurance in case somebody gets injured, there are the chances for medical sharing, which could offset that. But if you're holding on to normal insurance, the DPC is a little bit more added costs on the front end, but maybe preventing problems down the road.
Well, basically, if you belong to a direct primary clinic, again, likening this to car insurance, right? You purchase car insurance so that if you have a big old smash up, you can either get a new car or you can get your car fixed. But you don't purchase car insurance to change your oil and, fix your headlight and all that podunky stuff that goes on. But you do that maintenance to your car to keep your car running. So the same thing applies to healthcare. You do or should do the maintenance to keep your body running. You should exercise. You should eat correctly. Take a vitamin. Do the things that keep your body, your mechanical apparatus running correctly. And direct primary care, yes, tends to be more of a wellness sort of focus, because although direct primary care is about providing a physician and that physician's employees a income, direct primary care is more about taking care of the patient. The business of medicine works on illness. Illness makes money, okay? So direct primary care is more about wellness, and a person should have that insurance, just like they do for their vehicle, that will cover the catastrophic. Now, whether that is health insurance or whether that is membership in a cost-sharing program, a person has to make that decision themselves. And I'm going to throw out a plug here for, I want to say it's Senate Bill 2999. It's Senate Bill 2999 in the federal Senate, is a bill that seeks to allow people who have health savings accounts to use those health savings funds to pay for direct primary care memberships. And for a number of reasons, sort of tied up with the Federal Reserve and the IRS, not the Federal Reserve, sorry, the IRS, HSAs, the funds from health saving accounts have not been allowed to be used for direct primary care memberships. I suspect if that bill was passed, there would be a lot more people who would actually do DPCs because they want to see their physicians. They want, I mean, come on, Casey, when you go to the doctor, do you want to walk in sit there and wait for an hour, have the physician walk in with a computer, focus on the computer for 7 out of 15 minutes, look at you, say a few words, and leave the room? Is that what you want?
No, that's not at all what I want. And I think that's one of the hurdles for me going to the doctor is I want to go in and see Dr. Hornberger. Maybe if I see you in the store, I say, hey, how are you doing, Gayle? I want to come in. You know me, and I want to identify that there's a problem. Because another thing is that I've heard, I don't know how many times, it's at least 5 or 6 times that I've heard of different people talk about they went in with a problem and they said, hey, this is an issue. Maybe you're feeling extra tired right now. And the doctor says, well, that's just part of it or whatever. And with persistence, and it's because they didn't know the physician that they were seeing. With persistence, they get a test done, and it turns out that they've got blockage in an artery or something. That's just the most recent story that I've heard.
Mm-hmm.
But the patient didn't know that physician. That physician didn't know the patient. There's no way to know if the physician knew that patient personally. That physician would know. There's no way that this guy is, lazy and slowing down. He works 12 hours a day, 6 days a week, and he's 64 years old or however old. So this is a hardworking guy, and this is out of the norm, and that's what you can get with the DPC model. It sounds like.
Right. Well, yes, that is true, and interestingly enough, is many of my patients whom I'm, if I send them for a stress test or a colonoscopy or whatever, they'll text me as soon as they're done and say, "Oh, it went great," or not so great. I'm okay with that.
Let me talk just a second about some of the issues with DPC model, though. You're going to need to be somewhat selective of who you allow into your membership, I imagine. Otherwise, because you can't have a panel, if you're going to open it up to 600 people, you certainly can't have 600 people over the age of 65 and 90% of which have diabetes and are obese. Otherwise, you're going to go bankrupt.
Well, I would say, first of all, I'm not selective.
Okay.
I have people that attend my practice from all walks of life, and some of those people can't afford the DPC membership. And so I either provide their care for free, or they bring me flowers, or they bring me bread, or I don't know. They come and they rake the stones off the driveway for me. So I might be different than many physicians, but I do feel that as a physician, I have an obligation to take care of people. So no, I really don't screen my patients. However, having said that, there are people that will come to see me and they don't like me. My style of caring for people does not fit with them, and so they go elsewhere.
That's going to happen. I imagine you're providing some sort of service and care, and there's a lot of different options. Another thing people would say would be, well, you used to have a panel of 6,000 patients. You're down to 500, 600.
Mm-hmm.
If that happens nationwide, there's not going to be enough providers because, now there's going to be a physician crunch.
And that is one of the arguments: fewer patients to a doctor, so there are going to be less physicians available, and that then speaks to the issue of the term provider. And in the United States, we actually have just this burgeoning population of physician assistants and nurse practitioners. Advanced nurse practitioners, or now they call them doctors of nursing. And I have worked with many nurse practitioners. I've worked with many PAs. I have personally trained and employed 3 amazing physician assistants who did a great job. And I do believe that these providers can really assist in medical care, and they are assisting. But then we come back to the issues of, for example, urgent care, or the large clinics where they where people are run through. I call it cattle call medicine. I'm sorry, but I just
Well,
do.
that's
Where
people. I think people identify with that. I think people would say the same thing.
Yeah, and so in those situations, I think many times the nurse practitioners and the PAs don't have the supervision that they need. They don't go through residencies. They do not go through the training that all physicians have to go through. And so even though I know amazing physician assistants and amazing nurse practitioners, um, if I have to see someone for care, my preference is to see a doctor. We set up a plan and we figure it out. And then if that doctor's not available and I need to be seen, I might say, okay, I'll see the PA. But my preference is I want to see the doctor.
So there's the provider conversation. There is a lot of talk about, and it's been going on like this for decades. It's not like it's a new thing, but there is talk about, okay, maybe PAs, maybe nurse practitioners, maybe we need to free them up to see patients more freely without the supervision of a doctor.
Mm-hmm.
So that's one of the things. You could have a nurse practitioner that goes into competition with you, a DO, potentially in setting up DPC types of models. Right now, they wouldn't allow that, but that is one of the
Actually,
things.
they can.
Oh, they can?
Nurse practitioners can practice under their own license. Physician assistants right now, if they want to set up their own clinic, they must have a supervising physician.
So the
collaborating physician is what it's called.
The nurse practitioner can do it on their own, but the PA can't?
Correct.
Okay, that's interesting to me because like I said, I don't go into the hospital frequently. I don't work there. I don't know how that works. So that's why it's such an interesting topic to me. So the nurse practitioner, I could see a great benefit to them. Let's just talk Alaska, to a nurse practitioner that's willing to travel to rural, underserved communities.
Mm-hmm.
That I think that would help out great.
Yeah.
I can see where that would work. I think if I'm a consumer and I'm in Fairbanks, I'm in Juneau, I'm in Anchorage, I've got options. I think I'm going to want to see a doctor. That may not even be the right thing. Maybe a nurse practitioner can provide service just as well as a doctor. I don't know, but I'm just going to want to see a doctor.
Right. So a nurse practitioner and a PA can provide basic care, and generally a nurse practitioner or a PA will sort of specialize. So like a PA might do family medicine, nurse practitioner might do cardiology, but there are some that set up their own standalone clinics, and I respect that. I think that's fine. My caution is just that they're not physicians, and unless you have to go through a residency and you have to go through the training to really understand what a physician goes through to gain the expertise and the training, the experiences that we get. It's just if you haven't done it, you don't understand it. And the average person nowadays really many times doesn't differentiate. They call the PA, oh, Dr. So-and-so, and I'm always careful to correct people and say, no, they're not a physician. They're a physician assistant. There is a difference, or they're an NP. Now, I do have to quick throw out that some of the most amazing nurse practitioners I've ever worked with were the old battle axe health nurses from the remote communities. I grew up with one of those nurses, and she was amazing. Don't see many of those anymore.
So I don't know what the main, the large scale hospitals, how a because nurse practitioners, etc., they have to have thousands of hours of work and etc., but it's not going to compare to the residency requirements of MDDO type of program, I'm sure.
They do have nursing experience. A lot of them nowadays are going right from nursing school into their quote unquote doctorate of nursing, and I think it really depends on the person. It depends on what you put into it and how much you're willing to study and read and keep up with current guidelines and that sort of thing. But I'm sure there are people who would argue with me. I personally believe you cannot replace the experience that a physician gets doing a residency.
Now, what about the business of the DPC? So you talked about the business of medicine. Now there has
Hmm.
to be something that's the business of an alternative form of providing, so concierge or DPC. Now those two are not the same, though they're kind of in the same category. But for you, the what type of staff do you have to have? What does that look like? Are DPCs going to be only successful in very populated areas?
Okay.
Not that Fairbanks is
Again,
super populated.
I'm losing you a little bit, Casey. So, first of all, concierge and DPC are two different things in my estimation, and I really don't like the term concierge applied to my practice. So, to me, concierge is you pay a lot of money and you get the physician that comes to your house, and they've got the van that's got the portable x-ray and so on, and sometimes they don't have all that, but you still pay a lot of money to have that physician come and take care of you. Direct primary care is more about getting primary care, primary medical care to the masses, basically, to for people to be able to afford to see their physician. And people will argue with me, well, it's so expensive. And I just say, yeah, right. And how many lattes do you buy a month? Do you have a gym membership that you're not using? What's your discretionary spending on a monthly basis? And
Well,
is your health worth that?
and
Okay.
people worry about these all the time. Oh my goodness, I absolutely cannot believe the cost of a gallon of gasoline right now in Bristol Bay. It's in Dillingham, $4.97 a gallon. I
Hmm.
can't believe that, but you're
Yeah.
willing to pay $13.99 a gallon for Coca Cola. But you
Right,
know,
exactly. Let's not go there, okay?
okay,
So I do want to speak to staffing, and I think this is pretty universal with direct primary care practices. So the business of the practice is, again, moving things back to where it's patient centric. The physician patient relationship is the center of the care. And in my practice, I have myself, I have an administrative assistant who I have also trained in some medical assisting skills, so she assists me with that. And then I have another person who comes in and covers when my administrative assistant wants to take vacation, which is very important. So really there are two people that work in this clinic, and what that means is that I, as a physician, then I end up doing vitals, I end up providing the B12s, if injections, if there's immunizations, I do that. um, it's definitely a team. It's not, you know, me going to see a patient who has been checked in and sanitized and notarized and stamped, and okay, doc, you can go in and talk to this patient for 7 minutes and leave, and then we'll pick up.
yeah, and
And
usually with you've got to file the entire thing on your iPad because it goes to my portal that I've got to sign up for, and then I get this. You have to type in two sentences that says this is what you should do over the next year, and we made
mhm,
eye contact only once or twice. That's in the mainstream.
yeah,
Those are my experiences that I've had.
yeah. Well, people, I've had discussions in the past with individuals who have said, well, your clinic cannot be a medical home. Um, and and I argue with that. We are a patient's medical home here because we know the patients, and so oh gosh, I'm blanking on the term, but a patient's medical home basically is they think in those instances of providing care as a team, and I would say that in those instances you have to have the team because you have so many people coming through, and that physician only has, you know, 15 minutes if they're lucky, 7 minutes face to face if they're really lucky. So you have to have someone who does the diabetic counseling and the B12 injection and you need to see the mental health specialist. Let's go over here. So you have to have that team, patient-centered medical home.
Another thing that you see a lot of in other clinics that I've looked at is you have both the primary care and you have a lot of aesthetic type of treatments. So there's these add-ons that you can kind of, you can pick and choose. Maybe it's laser, Botox.
Right.
When you get down into the lower 48, it's just, massages, and it's attached to a gym, and maybe you have a doctor and a dentist together so you can get a teeth cleaning and a teeth whitening. There's all sorts of, pick and choose as you go, but most of them are just, most DPCs are a small physician directly to the patient.
Right. Can I say one thing about insurance, Casey?
Yes.
So an argument against direct primary care is that with direct primary care, if a patient does have catastrophic insurance and they want to submit, something to insurance, then they're going to have to become involved in their insurance. And I hear this all the time. And I would just say to individuals, you should be involved in your medical insurance. If you are paying the cost of the premiums, which I don't know how much you pay a month, but
Almost
I have patients. Yeah, so I have patients that pay anywhere from $1,200 to $2,800 or more a month. If you are paying that much for health insurance, you should take the time to read your benefits booklet to understand what that covers, to know how to get a hold of your insurance company and be able to submit and be able to advocate for yourself when they deny things and say, why are you not covering this? People just sort of get insurance and they have their card and they feel like it covers everything. But I will tell you, insurance does not cover everything. And on a yearly basis, the insurance companies want to cover less and less and less.
And they leave it completely up to the provider to hire some sort of administrative staff, and then you're just expected to see the bill.
Right.
So you started out, you came out of school, you get done with residency, you start a normal practice, and you've grown into where you've decided to go to the DPC model.
Casey, can you repeat that, please?
Yes. So you went to normal school, you go to normal residency, you get done, you come out, and you have a normal mainstream type of practice. You get that sort of experience.
Yeah.
Now, with the model, if you are brand new, like you just come out of school and you want to be a primary care provider, are people just coming directly out of residency moving into this field? Is it more attractive, or is it the type of thing where you're going to go to a mainstream hospital? And I'm just talking about what's more likely. You're going to a mainstream hospital, and then at some point you decide to do something different. Would a new physician be able to come out and run an operation like what you have at Midnight Sun as a DPC?
I think that would be much less common. I've seen a couple of personal stories from physicians who, went through residency, found that they just, burnout, it's a huge issue now and was a primary issue in me going to a direct primary care model. So I think from a financial standpoint, I think it would be very difficult for a new residency, say a new family physician residency graduate, to move right into a direct primary care model. Most of what I've seen is DPC clinics that were physicians who had an established clinic or, an established practice and just reached a point where they said, I can't do this anymore. And instead of then shutting doors and, say, moving to the emergency room or urgent cares, which a lot of family physicians are doing, that's a whole nother topic, they said, well, I really want to take care of patients, but my health is important, so I'll do direct primary care. So I think it would be difficult for a resident coming straight out of residency to set up a DPC. Anything that you read about establishing a DPC clinic says be prepared, have at least 3 years of savings, be prepared to struggle. And I have to say that, like I said, I know HVAC and plumber specialists who make far more money than I do. We run on a pretty fine line at this clinic, but I am able to provide really excellent care to my patients in the way that I think people deserve to be cared for.
For your clinic, when you moved into your clinic, you already had the building, I assume. You already had all of the equipment, etc. So that wasn't the overhead cost. For yours, if you were beginning again from scratch, do you have a lot of equipment that goes into running your clinic, or is it pretty basic? Because you said you didn't have X-ray, etc. So you pretty basic equipment.
Well, when I moved from a standard mainstream medical practice to direct primary care, I actually was renting space, and of course, because it's a medical space, it was incredibly expensive. It was about $10,000 a month, and I was able to use my own savings, and I had a small clinic built. So I have my own small clinic building, and I have the basic equipment. I do cholesterol panels. I can do glycohemoglobins. I can do, just basic, I call them little labs. They're called CLIA waved labs here in the office. But no, I don't have X-ray.
So the cost to start the clinic are not necessarily the hurdle. The hurdle is bringing customers in, getting consumers to decide, look, I'm not going to go to Providence Regional for my primary care. I'm going to go see Dr. Hornberger. That seems to be more the hard problem.
Right. So I think the hardest part with direct primary care has been educating people. And again, comes back to the business of medicine. For so long, people have had that little plastic card. Oh, I've got insurance. It covers everything. And so they say, well, why would I spend an extra, $50 to $150 a month to come and see you, and my insurance will cover everything? And then they go, they see the PA, or they see the nurse practitioner, or they see a physician for 7 minutes, and they're happy with that. So the hardest part is just re-educating people really about what healthcare should be like. And I don't know, our American ideal of healthcare has greatly changed. The physician-patient relationship for many people no longer matters. It's just, I want care, and I want care now, and I'm going to go to where I can get it right now.
Well, and you have a pretty significant move towards perhaps providers should be, perhaps all of our care should be free, universalized, which if you were to universalize it, I think that would pose significant problems. I was once in the military. I see that the military care is great for while you're in service, but one of the things that nobody takes into consideration is that it's one of the most highly selective organizations in the country. So you have generally male or females that are in great physical shape. They're between the ages of 18 and 39. They have young families that don't have huge costs. So service or care while you're in, if you're at Fort Wainwright for service members, that's great. But it's not very good in the VA once you start mixing in all of the medical ailments of old age or other treatments that are no longer self-selected out. So
right.
that's a major problem, and nobody will talk about that realistically. But that's also another topic. I hope that maybe we can talk, months from now, get updates from you about some of the other things. One thing that's interesting to me right now, one of my brothers lives in China. He can't speak to me that much about the coronavirus outbreak. We speak over WeChat. There are some concerns if he speaks to me too much about numbers, etc. He can't be in trouble for causing hysterias and stuff. What do you think about how coronavirus is going to go? Any recommendations for that? We're ready for it. We're not ready for it.
Well, I think the straight on answer is yes, it's going to be here. I personally think by the end of March, we'll probably have cases in Alaska. I think there's a lot of hysteria over it that is not necessarily warranted. The influenza actually has worse statistics. So if you haven't gotten your flu shot this year, you should get your flu shot. But basically, people just need to be prepared. It's funny that you asked this. I actually was thinking about this morning. Is that wash your hands. Don't touch your face. There's the 4 principles of hand care, and it's wash your hands before eating. Don't touch your face. Don't sneeze into your hands. Essentially, it boils down to personal hygiene. And I've had a lot of people asking me, well, what do I do? I've got a trip planned. Well, take your trip, but be careful. Take a mask with you and, sanitize your airline seat. Use hand sanitizer always. If you're near someone who's coughing and spewing, ask to be reseated or move if you can. Take health precautions that we as citizens don't always do, and take care of yourself. If you're unhealthy to start with, your risk is higher. So if you're not exercising and you're not eating a healthy diet and you're not taking care of yourself, then yes, your risk is higher. How's that?
Well, that's good. I mean, it's close enough. I'm not terribly concerned about it. I was just recently, luckily, you or anybody listening can't get coronavirus from me, but we've been joking about it because I was just recently in LAX and Seattle airport. I mean, by recently, I mean like in the last 10 days. Mm-hmm. So that's kind of been the areas where people have been worried about it, LA and Seattle. So we'll see what happens. Maybe it will be a bad deal for me. But if you were to, in summary, if you were talking to me, we ran into each other at Freddy's, and you said, this is why you should switch to a DPC clinic tomorrow. This is me with my wife and 3 children. Mm-hmm. What would be the number one reason why?
What would be what?
What would be the number one reason why? Is it because of cost, or is it because of what the relationship that you get with a physician, or what's the number one draw for me to come and see you?
Well, I think as a consumer, the number one draw is cost. From a physician's standpoint, it's the enduring care that you receive, the type of care that you receive.
Well, I have really appreciated talking to you. I think that there's maybe 1 or 2 clinics like yours in the state. They don't seem to be catching on as much as they are in other states with higher populations, but it's a really interesting model. It's interesting to learn about, and sometime in the future, it'd be great to talk to you further as I develop more ideas, talk to more people about exactly how a DPC works. So I really appreciate your time, the almost hour and a half that you gave me. And if we started going down the rabbit hole of insurances, number one, I'd get extremely frustrated with it, and it sounds like you've had enough experiences that are negative there. But maybe we could talk about insurance sometime, just specifically dedicated to it down the road.
I would be open to doing that, Casey. It's been great talking to you, and I just, again, I come back to we have a mutual thread in John Libby. He was an amazing man, and I attribute much of my love of medicine to what I was exposed to through his care. I'm a family doctor through and through, so thanks for letting me expound on that.
I'm glad that we have the connections to Bristol Bay. You may have at one time younger, when you were talking with John Livy, known Dr. O'Connell, some of the other people in Bristol Bay that have been out here for a long time working to keep people healthy. But very interesting tie that we have, and I look forward to talking to you again soon.
Yeah, me too. You take care.